Okay, well, we'll get started and then people can join as we get going. So hello, I'm Sophie and I'm one of the final year medical students, and I'm on the committee for Leicester Wilderness Emergency Medicine Society. Tonight I'm going to be delivering a presentation, as you know, for paediatric emergencies. So obviously it's not going to cover every single emergency that you would encounter in paediatrics. It's just covering kind of the core ones that I think are important to cover. That you see come up a lot in exams and in the department itself. And also it's obviously not going to cover absolutely every aspect of every disorder that we talk about, but I'll do my best to give you kind of the key points, and then I've given you some resources at the end so that you can go away and do a bit more research into it yourselves. So we'll get going. So these are the topics that we're going to cover today. So we've got, in general, the assessment approach to a seriously unwell child coming into the department. We've got brief, resolved, unexplained events, or as it's also known, apparent life-threatening events. Seizures, different types of fractures that you might see in children, and then respiratory distress, and that will include a variety of conditions within that. And then paediatric and neonatal sepsis we'll touch on briefly as well. So first up, how to assess a child when they come into the ED. So it's important to note the differences between children and adults when you're doing your general assessment. There are a few key differences, but other than that, you would just do as you would in an adult, an A to E assessment, if you're worried about a child in particular. So the differences being that the airway is assessed in a different way, and that changes depending on the age and the size of the child as well. So obviously you're aware that in adults, you'll do your head tilt chin lift to make sure the airway is open and that you can see inside it and check that it's clear. But in children and infants, it's slightly different just because of the anatomy and the sort of laxity of structures in that area. So in an infant, you'll want to have their head in a neutral position, so just looking straight up, so their spine is nice and straight. And then in young children, sort of toddlers upwards, you want them in a sniffing position, so just kind of like they're sniffing the air. You have to be aware that hypertension is a very late sign of circulatory shock in children. They're really good at compensating physiologically until suddenly they're not anymore. So if you're seeing hypertension in a child, do be concerned. Sometimes it's very hard to get good IV access in children. They've got very small little vessels, and they can be very weak and hard to cannulate. So one thing to bear in mind is to not hesitate to get IO access, so intraosseous access into the bone, early on in children that it's difficult to get peripheral access in. So it's more important to get any fluids or medications in than fanny about trying to get IV cannulas in. With children where they've got a reduced consciousness level, you have to have raised intracranial pressure high up on your differentials list, okay? Especially if you're suspecting non-accidental injury, sort of shaken baby or anything like that. That is just a common presentation of raised intracranial pressure with children. And then you want to make sure as well to look out for bruising when you're on the E part, the exposure part of the A to E assessment, because you're wanting to consider non-accidental injury. So you're not just looking for bleeding or any signs of trauma or incontinence and things like that. You are looking for bruising and signs of abuse as well. Another thing to bear in mind is when you're examining children in general, obviously with consent from the parent and if they're old enough, the child themselves, but you do want to take their nappy off and have a look down there as well, because it can be helpful in checking whether they're wetting their nappies, and sort of any changes to fecal consistency and colour and things like that. And also in a lot of young children, things like testicular torsion, blah, blah, blah. That's a more general peds point though, so I won't dwell on that. But I've just popped a table in there for you just to remind you of the kind of things you look for and the slight differences you might see in paediatric A to E assessment. You want to obviously make sure that you get a really good history once you've done your AT assessment and stabilised the child. So often it's not going to be from the child themselves. It will probably be with their parent or legal guardian. And that makes it interesting as well, because it can kind of automatically become a bit of a triadic consultation, and you've got to kind of take into account not just the impact of the illness on the child, but on their family as well. You've got to bear in mind that often children are really frightened and it's a new, scary environment. They might have needles coming at them. So really try and put them at ease, get on their level. Understand that they'll have a reduced ability to tell you or explain their symptoms, but the more you kind of see paediatric patients, the more you get used to the sort of words and gestures that they use and how they present with certain conditions. And obviously you've got to adapt your communication style depending on the age and maturity level of the patient. If you're seeing a teenager, then it would be fine to just get the history from them, and then maybe mum or dad will chime in with a few points. But with a younger child, you're going to have to get most of it from the parent. And you'll want to kind of talk in your best child entertainer voice rather than just as I'm talking to you now. So there's a good acronym for remembering the additional parts of a history that you need to include in a paediatric history compared with adults. So that's BLINDS. So you want to include the birth and antenatal history. So that includes everything from when the mum knew she was pregnant. Were there any complications? Did she attend all her scans? Were there any problems with the scans or the blood tests that she had? How was the baby delivered? Was it vaginal? Was it C-section? Was it an emergency? Was it planned? Any complications? And also how far along the baby was at gestation at birth. The L is looking for risk factors for neonatal sepsis, so things like premature rupture of membranes, if the mum was diagnosed with chorioamnionitis, so infection of the amniotic sac, group B strep infection in the mum, and also any preterm labour, so anything before 37 weeks gestation. I is immunisation, so you want to always get an immunisation history, even up to, you're seeing the 16, 17-year-olds. You want to make sure that they've had all their immunisations up to that point, and if not, what they're missing. Nutrition, so in older children, just general nutrition. Do they eat and drink well? Are they fussy eaters? Are they lacking any nutrients? Have they changed their feeding pattern recently and gone off their food? But in younger children and infants, it'd be like method of feeding. Are they bottle or breastfed? How much are they taking on and how often are they feeding? And have they weaned yet? If so, how did that go? Then we've got D is developmental history. So obviously I'm not going to go back through them all right now for you, but just a reminder that you need to kind of be aware of some key developmental milestones, and have they met those so far. There is a really good sort of cheat sheet of them on Teach Me Pediatrics under history, the history section. It would just tell you the kind of like major ones to know, so you don't have to go through all of them, but like sitting by 6 months and things like that. And then the final one is screening for mental health. And this has kind of been emphasised since the whole COVID pandemic, because we saw a lot of teenagers coming in struggling with their mental health in particular. There's various assessment tools you can use for that. One of them is called HEADS with 2 S's. You can look that up in your own time. But also just having a general chat to them if you need to get their parent or guardian to leave when you're having any difficult conversations, maybe about sexual intercourse or drug and alcohol misuse and things like that with your older teens, then don't feel bad for doing that, because they might not tell you the truth with their parents in the room. Then we've got examination. As always, you're going to do a good systematic examination as you would in an adult. The only thing is, I think there's some important points to make with children. You need to kind of get down to their level. Don't be like leaning over them, kind of crouch down. It really helps feel less intimidating to them. Use some icebreakers. Have they got a teddy with them? Oh, what's teddy called? Try and get on their level in that way as well. Observation is really important. So even when you call them through from the waiting room, if they're a bit more mobile, having a look, like, are they limping or are they holding their tummy in a particular way? It can give you a lot of clues. Adapt your approach. as needed, depending again on how old the child is and like how they seem to be dealing with the consultation. So just be prepared to kind of move things around, and not do everything necessarily in the right order, or the order we've been taught. I got told a really good tip from a GP in third year, and he said he likes to leave the kind of scariest or the most uncomfortable things until last. So a lot of kids don't like having their top off and having a stethoscope on them, so he'll do like that last, or like putting an otoscope in the ear. Kids will hate that, so try and do that as quick as possible and do it at the last minute. Just a few tips. Anyway, so that's kind of the assessment of a child in general. Moving on now to brief, resolved, unexplained events, or they're also known as apparent life-threatening events. So they go by both names. So the definition of that is any episode that is frightening to the person that's observed it. So usually mum or dad, or it might be a nursery nurse or whatever. And during that, a combination of the following symptoms are reported typically. So they might get apnea, so stopping breathing completely for periods of time. They may change in colour, they might go purple or blue, get a bit cyanotic, or they might go really red in the face because they're holding their breath. Some choking or gagging, and they might have change in tone, so sometimes you might see a floppy infant. And usually by the time they come to A&E, actually, as it says in the name, it's a resolved unexplained event. So it's resolved itself. The baby looks really well again. It's like nothing's happened, but you'll have a really panicked parent worried about what's just happened to their child, and they're going to want answers. It's a tricky one, though, because in 50% of cases, the cause does remain unknown despite investigation. So that's something you kind of got to discuss with the parents. But taking a really thorough history and examination will help you to find any cause if there is one. So it's fairly common. It's 1% of emergency presentations of infants under 1 year old, which doesn't sound like a lot, but if you think of how many come through the doors of A&E, it can be quite a high number. 2% of hospitalised children, so they do try and avoid hospitalisation in these children if possible, but 2% get through. There's a 6 to 5 per 1,000 live births is the incidence rate. Typically happens around 8 weeks of age, so really quite young, and these are new parents and it might be their first baby, so you can understand why they would be so panicked. And seems to happen in boys more than girls, according to the data. Popped a table in there with potential causes. Again, I won't waste time going through all these now, but they are there for you to kind of look into in your own time. But you can see that it's really wide range of causes that can lead to these events. So it's important to really do a thorough examination. And if you find any abnormalities or suspect something might be the root cause, to investigate that further. So history taking with these sorts of events, you want to get a really, really clear description from mum or dad or whoever saw it of the timeline of events, what exactly happened and when, how long did it last, did they see anything strange, any arching of the back, or any vomiting when they're feeding, have they had any episodes like this before, and if so, how many? Was it different this time to what usually happens, or has it been quite similar, and how long do they typically last, things like that. You want to inquire about the sleep conditions of the baby. So not only are you kind of worried about sudden infant death syndrome risk factors, but also there's certain conditions that can be exacerbated by lying flat during sleep. So that's when these events can often happen. So reflux can be a lot worse when they're laid flat. So ask if the parents have got the head of the cot elevated. Also, along the same vein with reflux, symptoms might improve when the baby's held upright. So if that's something the parents have noticed, then that's helpful to know. Do they have any sleep risk factors? So are they co-sleeping with parents? That's not really advised. Have they got a lot of toys and blankets and things in their cot? Things like that. You can have a look at the kind of safe sleep guidelines that they put out nowadays. They change quite often, so it's good to keep up to date with that. It's good to do a general systems inquiry. So you want to ask, have they been unwell recently, or has this come completely out of the blue? Have they had any recent cough or fever, any signs of an upper respiratory tract infection in them or in the family, or anyone they've had contact with? And then you obviously want to make sure that you're getting a good past medical history, family history, social history, immunisation history. With the family history, you want to include asking about if anyone in the family has had any sudden death, so just passed away quite young and unexpectedly. Any cardiac abnormalities in the family, any inborn errors of metabolism. Hopefully they would have had their Hill prick test to screen for those, but obviously if they're quite young, they might not have had their results back yet. Then we've got social history. You want to include screening for things that might point in the direction of non-accidental injury, and any safeguarding issues. Okay. That is that. And then investigations and management wise, it depends really what you think could be the cause. Like I said before, a lot of patients, you never find a cause, and there might not even be one suspected. You think it is just a brewery or an RT, and we'll send you home with monitoring and advice. So you can kind of assess whether they're high risk or low risk patients, and low risk features typically if they're older than 2 months, if they were born after 32 weeks, so they're not super duper premature, if the event lasted less than a minute, they didn't need any CPR by a healthcare professional, and if there was no real concerning features in the history examination. These are the patients that you'd probably do a swab for pertussis, and you might do an ECG just to kind of cover all bases, maybe a set of bloods, and then you'd probably send them on their way if they're all normal, and just kind of give safety netting advice. For high risk patients, you probably do want to refer to the paediatric team for admission just to investigate further. So it's kind of the opposite of the low risk criteria really. So like really young, very premature, long lasting episodes, they needed CPR, or you're a bit worried about something in the history examination. And in these patients, you want to do a chest x-ray, even if there's no chest signs on examination, just to kind of make sure there's no focus of infection that's getting covered up. You want to do a blood gas. In paediatrics, you typically do a capillary blood gas, so it's like a heel prick, and they'll do it into one of those little tubes. And you'll definitely want to do some bloods. And if they're high risk, the parents will be given BLS training before their child is discharged, so that if one of these happened again and the child did arrest, they'd be able to recognise it and intervene really quickly. Right, moving on. Seizures. So it's a massive topic, and obviously there's lots of different causes for seizures in both adults and children. So again, it's really important to take a really good history. So these are kind of the key things to think about when you're taking a history from a parent or whoever's witnessed the seizure, to kind of rule in or out actual seizure versus like a syncope or something like that. So have they been incontinent? Obviously, in a really young child, they're probably going to be incontinent anyway. They'll probably be in nappies, so it's harder to say, right? But in older children that are dry normally, you definitely want to ask about that. Has the parent witnessed rhythmic tonic or tonic-clonic type movements? So you need to kind of describe what that means to them, and try and distinguish that between the sort of like jerking movements that you sometimes see in syncope, which is hard to do. It's helpful if they've got a video of when it happened, but obviously, especially if it's the first time, a lot of parents won't have the presence of mind to, I'm going to get my phone out and record them. But if they do, then amazing. Eye deviations with flickering, so are their eyes flickering, rolling in the back of their head, or going all funny? Have they had any tongue biting, particularly laterally? So are their teeth biting down at the sides of their tongue? And really importantly, have they had a post-ictal phase? In children especially, no post-ictal phase, so no confusion or disorientation or upset after the event, makes it really, really unlikely to have actually been a seizure. So differentials in this instance would include syncope, so fainting, pseudo seizures, and cardiac conditions. So maybe POTS or some sort of postural hypertension, which is quite rare in children, but it could happen. So yes, obviously you want a bigger history than that, but these are really key points. You want to know how long it lasted, how often it's happened, has it happened before, blah, blah, blah. So one really common cause of seizures in children is febrile convulsions. So it's not like an epileptic seizure. It's very, very common in children between 6 months and 5 years of age. It's normally a single episode. It's normally a generalized seizure, and it will be very short-lived compared to an epileptic seizure. It's usually tonic-clonic, and it will have a quite short post-ictal phase, but it should be there. And importantly, the child does seem to return to neurological function, like normal neurological state, quite soon afterwards. A really important point is to not fall for what I've called handover Chinese whispers. So it's really easy for a parent to say, oh, I think the child's been a bit feverish, and then the paramedics say, oh, the child's had a fever, hands over that to the medics, and then no one actually has checked the temperature at any point before or during the seizure. They might have one now, but unless a fever has been documented before or during the seizure itself, it's unlikely to be a febrile convulsion, a true febrile convulsion. There is a 33% risk of recurrence, which is actually quite high if you think about it. So a third of these children that have them will go on to have a further febrile convulsion. So you do need to warn the family about that, and just kind of, again, they need to know the signs to look out for when they need to call for help. And that risk of recurrence does go up if they've got a family history of febrile convulsions, so mum, dad, even siblings. And also, the younger the child was at the time of their first ever febrile convulsion, the higher the risk of recurrence. It's deemed to be a complex febrile convulsion if they've had multiple of these within a 24-hour time period. And in that case, they need admitting and they need investigation. It might be that they have a brewing sepsis or meningitis or something like that. So managing seizures in general in children, if a child has come into the ED, they're still seizing, or you see a child have a seizure on the ward, then this is the kind of algorithm you want to follow. So obviously, the initial thing to do is to administer oxygen, do your A to E assessment as normal. Check blood sugar is really important because hypoglycemia can be a really common cause of seizures in children. Make sure someone's keeping track of how long the seizure has lasted. If it's gone on longer than 3 minutes, it's really unlikely to spontaneously resolve on its own in children. So you need to be getting kind of medications ready and think about your next steps. And then you want to ask about the past history of seizures, especially. So just going through this algorithm briefly. If they're not coming around after 5 minutes, then you want to go for your first line treatment option. So that's your benzodiazepines, okay? Obviously, ideally, they would have IV access, but within 5 minutes, trying to get peripheral access in a child, you might not be so lucky. So your other options are buccal midazolam or rectal diazepam. Obviously, buccal would be a bit nicer than rectal, but if they're old enough to have teeth, then just be careful of your fingers. Then you have to wait 10 minutes to see if that medication has worked. If it hasn't worked after 10 minutes, we're going to repeat that. So we're going to give another dose of benzodiazepine. If you've got IV access at this point, you can change it to lorazepam. And obviously, just bear in mind, like all medications, dosed based on weight of the child. So if you know that, then that is very helpful. If not, you kind of have to estimate. But the paediatricians are very scarily good at that. And then if you've repeated it and you've waited for the medication to work again and it's not worked, you want to go to your second line choice, and that is phenytoin. You want to give that over a really slow infusion. I believe it's over 20 to 30 minutes. And definitely not giving it as a bolus or a continuous infusion. That can have some really serious side effects. So seizures that aren't febrile in children can have a variety of causes as well. So again, history is absolutely key, especially if this is the first time. Always measure that blood glucose. If they're older than 6 months and they seem neurologically well, and there's no obvious cause that you can find for the seizure, then don't bother doing any other investigations. Also, that's what the guidelines say. You can do your basic observations. If they seem stable on that front as well, they're not scoring on the pews, then it's unlikely to be helpful to get any other investigations done. You should always consider non-accidental injury though, so just make sure you're doing a really good primary and secondary survey. With afebrile seizures, things to look for in the history and examination in particular is that inconsistent history and unexplained bruising, so that would be indicators of non-accidental injury. Café au lait spots, so that's the top image there, and that could be a sign of neurofibromatosis. Ash leaf spots, and that's seen in both of those bottom images. That could be a sign of a condition called tuberous sclerosis. I wouldn't say you have to know that much about it for Leicester exams anyway, but it's one to be aware of. You want to look for signs of meningism, so sort of neck stiffness, photophobia. You can do the official Brudzinski sign, I think it's called, and all of that jazz. And that could be a sign of not just meningitis, but intracranial bleed as well. You're looking for any dysmorphic features, so any features that might indicate inherited conditions such as Down syndrome, because that will just give you a bit of a clue. They can have a higher incidence of epilepsy and things like that. And then you want to look for any hepatomegaly or jaundice as well, because that could be a sign of metabolic disease. Okay, that was a lot. I'm sorry. Another thing to bear in mind is if you're seeing a child in the emergency department that has seizures, the safety netting advice you want to discharge them with, because they'll probably go to a fit clinic. But in the meantime, you want to make sure that they're not having showers or baths unattended. Obviously, this is older children. Younger ones will always get attended anyway. So don't tell them not to lock the bathroom door when they're having a shower. To just be aware of any activities they're doing, so anything that might be dangerous if they were to have a seizure during it, and then just educate on supportive measures really, and ask them to keep a bit of a fit diary so that when they go to see neurology that they've got all the information there. So moving on to fractures. I'm not going to go super in depth into all of the fractures, but I think it's really important to know how the types of fractures differ in children and how kind of assessing them and managing them is slightly different. So obviously you've got to bear in mind that children are still growing, so any fracture to a bone now could have potential implications on a child's bone growth in the future. So it's really important that we identify them properly, treat them really well, and make sure they're in good alignment and things like that. So a few things about children's bones: they're less brittle and more malleable. So you'll get a lot of incomplete fractures in children, sort of your green stick injuries and things like that. Or often you'll get a bowing injury. So the bone will be bowed into a sort of bent shape, but it won't necessarily have completely fractured. You might not see a fracture line as such. Comminuted fractures. So they are like complete fractures. They are less common in children, and that is because the ligaments are more lax in children, but they're stronger. So you're more likely to see a growth plate or an avulsion fracture where those ligaments attach onto than you are to see a full break of a bone. Luckily for children, bone healing is faster because they're still growing, so they've got all of the nice sites and osteoblasts and osteoclasts and all those good things to rebuild bone nice and quickly. And they tend to heal with fewer complications as well than in adults. There can be a greater amount of angulation and displacement in fractures before you become worried in children, because they can kind of correct for that a bit better. And there is a lower incidence in the first place of fractures that are displaced and open fractures as well in children. Basically, their bones are a bit soft and bendy, which kind of plays in their favour a lot of the time. They also get a bit less stiffness after immobilisation, and that's generally because they don't need immobilising for as long a time as adult bones, because they can rebuild their bones so quickly. Remember to consider non-accidental injury once again in children with fractures. So especially children that aren't old enough to be mobilising independently yet, that have a fracture in a strange place, maybe a skull fracture or a rib fracture, or a femur fracture. And if the history from the parents is really inconsistent as well, then it's just something to bear in mind. And if you're worried about non-accidental injury, it's usual practice to do a skeletal survey, which is kind of like a full torso at least x-ray to check for any old fractures that haven't been treated. So I've kind of put down some of the most common bony injuries and fractures that you might see coming into the PDD. So a pulled elbow is a super common one. I think I did 2 shifts on 2 or 3 on PDD and minor injuries during my ED block, and saw maybe 4 pulled elbows, which I think is quite a lot. And that is what happens when you have a parent maybe like dragging a child across the road, not in a horrible way, but they're just kind of going, "Go on, come on," and they've pulled on their arm. And in a child under 4 years of age, the radial head is really, really small and not quite developed yet. So it can sublux, so not a full dislocation, but it will partially dislocate under the annual ligament around that area. Okay. The good news is it's really easy to treat, and you literally just hold their arm and get them to, like, you twist it, you're holding their hand, and straighten it out, and it will pop back into place 9 times out of 10. And then they'll get a lot of real instant relief from that, even though it's painful while you do. Then growth plate fractures. So these are fractures that come through the growth plate. I'll discuss a little bit on the next slide about the different types of that. And it's because obviously your growth plate hasn't finished forming and is still a bit softer and everything, so it's more likely to go through, so it's quite common in children. And it's typically a torsion type injury, so kind of twisting motion. Toddlers fractures. So this is when toddlers are kind of still tottering around a little bit, and their feet will be flat on the floor, and then they'll fall and put their arms out or something. And they kind of like fall in a rotational kind of way. And that causes a really characteristic spiral or oblique fracture, usually of the distal tibia. Okay, so it's quite a niche fracture type, and obviously there's a limited age group that you'll see that in because they're toddlers. And then the final one I mentioned is supracondylar fracture, which I can never say. The peak age of incidence for this is about 5 to 7 years. So kids on playgrounds, usually they'll be hanging off monkey bars and they'll fall, and it's a fall onto an outstretched hand, usually with the elbow fully extended. And so it's just above your elbow here that it will happen. You need to be quite careful with these because obviously you've got a lot of neurovascular structures running down that radial groove, so your radial nerve, radial artery, things like that. So there is a big risk of neurovascular injury, and you do want to really do a good neurovascular assessment as much as possible on these children so they don't end up with complications for the rest of their life. So Salter-Harris classification is a classification system used for those growth plate bony injuries. So it's type 1 to type 5 luckily they made it slightly easier in that type 1 to type 5 it becomes more severe as you go down the list, so that takes one element of guessing out of it in an exam scenario. So type 1, you've got a transverse fracture through the physis, the growth plate itself, and that means that the epiphysis separates completely from the metaphysis. Okay, so the metaphysis is the bit closest to the middle of the bone and the epiphysis is the bit further away. Type 2, you get a fracture through the physis again, but you've also got a little triangular segment on the metaphyseal portion of the bone. This is the most common type of Salter-Harris fracture. Types 1 and 2, it's important to note, have a very good prognosis. They normally heal really well, minimal complications. So type 3, you have that fracture through the physis, but then you've got coming through the joint, you've got a fracture through the epiphyseal portion, which makes it inherently intra-articular. This is quite rare. You won't see this very often. Type 4 is a fracture through that epiphysis, through the physis again, sorry. And then you'll have 2 further fractures. You'll have one coming through the epiphysis and then another one coming through the metaphysis, which is normally sort of an oblique plane. Again, this is an intra-articular injury, so slightly more complicated. And types 3 and 4 have a much worse prognosis, struggling for that bone to continue growing after the injury, and angular deformity as well is really common in these 2 types of fractures. The final type, type 5, again, luckily very rare, but it's a crush injury of the physis. So the physeal plate is crushed in the middle of where the metaphysis is and the epiphysis is. So you've got this nice spongy bit that's growing and growing and growing, and it gets crushed. And these generally have a really poor prognosis. And that's because when you've got that crush injury, you're affecting the blood supply to the epiphysis, which means that's really hard to for that bone to continue growing. And unfortunately, it's really hard to see on X-ray, and you might not see it on X-ray, even if you're an orthopedic doctor. And a lot of the time it's diagnosed retrospectively. So a child comes in and their limb is deformed in some way, it's not growing properly. And that's when you look back and then you can see the damage that's been done. Just a brief touch on safeguarding in non-accidental injury, because I know I've mentioned it a lot already in this presentation, and obviously fractures is a really common thing that you'll see in the context of non-accidental injury. So this is a really helpful summary. I'm sure you all know by now, but this EM3, not company, but group of people that put these together, really helpful. They happen for a lot of conditions in emergency medicine. So I've just put that summary there. So you're what sort of things you're looking for, what you should consider, and how that relates. And then it's got some guidelines for you there. I thought in particular actually on this one, the safeguarding checklist is very, very helpful, because it reminds you of the sort of things to ask and look for. And then you can weigh up and balance out whether there could be a risk of non-accidental injury. Right, I need to get moving, don't I? I don't want to keep you too long. Respiratory distress. We'll go through that next. It's quite a bulky topic, but I'll try and summarise. So there's loads and loads of reasons that a child might present to you with either just breathing difficulties or actual respiratory distress. So viral infection, bacterial infection, it might be an asthma exacerbation. It could be allergies or anaphylaxis, or they might have inhaled a foreign body. There are other causes as well, like smoke inhalation, passive, smoke inhalation if their family members smoke and things like that. But those are some key ones I've popped there. And then the signs of respiratory distress or breathing difficulties can include things like a cough, a wheeze. They might have a runny or a blocked nose. They might have lots of sneezing, increased respiratory rate, and then signs of an increased work of breathing. So nostril flaring, are they working really hard to try and drag oxygen in through their nose and their nostrils are flaring? Are they grunting as they're breathing? It's really, really hard work. Have they got a tracheal tug? I'll show pictures of some of these on the next slide, so don't worry, but it's when the bit where your trachea sits here in between, in the sort of sternal notch, retracts in on itself because they're really gasping for breath. They might have central cyanosis, so little blue lips, and just generally looking a bit pale. Drowsiness, and that's a really worrying sign because they're not getting enough oxygen to their organs. Stridor, so the kind of like Eeyore type sound, like really trying to get something, that's usually an obstructive sign. And then intercostal and subcostal recessions as well. So here we have tracheal tug. So it's very subtle, and it might be on babies and little chubby toddlers because they'll have a lot of like little cute scrummy rolls around here. But you can see there's a slight recession there where the trachea would sit. So that's what you're looking for. This one here is subcostal recession. So you see just underneath the border of the ribs, they're drawing in air, their diaphragm's working really hard to try and get a lot of air into the thorax, and they're sucking in their tummy as they do that. And then we've got intercostal recession. So you can see there that in between the ribs, you have those little dips. And that, again, is your intercostal muscles working overtime to try and compensate for the difficulties you're having. I'm afraid this table is a two slider. So these are the kind of conditions that I mentioned earlier. I've popped the common signs or symptoms that you might see. A lot of them are really similar because they're all respiratory type conditions, to be honest. So depending on if it's an infective cause, you'll get sort of the normal breathing symptoms, and you'll often get like a fever, coryzal symptoms, and maybe some rhinorrhea, so a runny nose. With younger kids, so sort of like, 8 and below, you might even have them off their food. In babies as well, like it's really hard for them to breathe whilst they feed anyway. So if they've then got a respiratory issue on top of that, they will go off their food because it feels kind of suffocating for them to eat or drink their milk. With most of these conditions, the decision on whether the child needs admission to the hospital depends on the condition, like on your clinical assessment of the child. So if the child's looking really unwell, has signs of severe respiratory distress, so those kind of signs and pictures I showed you before, if they have any sign of central cyanosis, low saturations despite oxygen, or is having any apneic episodes, so episodes of not breathing at all, they will need additional support in hospital, so they'll need admitting. But ideally in kids, a lot of the time you want to get them home with parents in an environment that they're comfortable in with safety netting advice instead. So bronchiolitis, these are the symptoms you'll kind of see. Management is mainly oxygen therapy, very supportive management with fluids. If you think they're going into respiratory failure, yes, ITU admission or high dependency unit and get them on CPAP. And maybe if they're over producing secretions, then you might want to do some upper airway suctioning. Bronchiolitis is caused by RSV, don't forget. So then we've got croup. These are the symptoms presenting with. Importantly, they'll probably have a stridor. Older kids, they'll have a hoarse voice, but that's a fairly late sign. With that, you want to give a single dose of oral dexamethasone if they can tolerate it. And then usually you just do that, send them home with safety netting, to be honest. If they need a bit more supportive therapy, then you'll give them nebulized adrenaline and oxygen if they need it to keep their SATs up. And then if it's moderate to severe, then you want to admit them. Asthma exacerbation, I won't bore you too long with. It's very similar to in adults, to be honest, in both presentation and also in management. So oxygen, your salbutamol nebulizers back to back, ipratropium bromide. If the salbutamol is not helping, they're going to need some steroids at some point. Can they tolerate it orally? Fine, give prednisolone. If not, IV hydrocortisone. And then if they're really, really poorly and it's very refractory, then they might need admitting to ITU for IV salbutamol, and magnesium sulfate can help as well, but that can be given in the ED. Part 2, we've got epiglottitis. That's a really important one to know. I'm sure you'll remember that from phase 1. The signs and symptoms are a bit easier to remember because it's the 4 Ds. So dyspnea, so difficulties with breathing, dysphagia, difficulties swallowing, a lot of drooling typically, and the hot potato voice. So I'm hoping you know what I mean by that. If you had a bit of hot potato in your mouth and you're trying to talk through it, they'll have a funny sounding voice like that. And usually the symptoms is quite acute, so the symptoms will last less than 12 hours, and there's typically no cough with this one, so that helps you kind of distinguish it from other bacterial and viral causes. With the management of this, you want to make sure that they've got a really secure airway. So if there's any airway compromise at all, you're looking at getting anaesthetics and ENT involved to pop an airway in. Oxygen, but you want to try and hold the oxygen mask near their face, not on it, because with epiglottitis, you want to really make sure that you're not stressing the child out any further, because that will really exacerbate their airway and compromise it even further. So you want to keep them as calm as possible, avoid too much examination of the area. If you're pretty sure it's this, then just get onto the treatment of it. Nebulized adrenaline can be really helpful. Might need IV antibiotics and steroids and fluids, so it's all like pretty supportive, other than sort of the airway interventions. Anaphylaxis, again, very similar to adults, so I won't bore you too much, and obviously you can follow the Resus Council guidelines for these, but there'll be a wheeze there, probably increased work of breathing, there might be a bit peripherally shut down, a bit cold and clammy, might be a bit of cyanosis, and hypotension, but like I mentioned earlier, that's a really late sign, so you'd be worried at that point. The most important thing is getting that IM adrenaline on board as soon as possible. Give oxygen if they need it, and again, if it's refractory to treatment, you're going to need to transfer them to ITU for further treatment. Okay, and then finally, foreign body inhalation. So with this, they'll typically have a stridor, because the air's trying to get itself around that foreign object in the airway. Might have changes to their voice, drooling again. They might be physically choking still when you see them trying to get the object up. And you might actually be able to see the object at the back of the oropharynx if you're lucky. And in that case, you might be able to fish it out with a pair of McGill forceps, those really long, scissory looking things. And if not, then they'll have to have an endoscopy, and the urgency of that kind of depends on what they've swallowed. A lot of things can wait, but one thing to remember, and this comes up on exams a fair bit, is button batteries. If that's in the child, you need to get it out as soon as possible, because it can wear through the esophagus if they've swallowed it, or the trachea if they've inhaled it. So it's really no good. Okay, this is our final topic. Don't worry, the end is nearly in sight. Paediatric/neonatal sepsis. So obviously it's hammered into us, the normal sepsis sort of algorithm and sepsis 6 pathway. There's a few changes to note in children, and just a few different risk factors to be aware of. So neonates and really young babies, so under 3 months old, are at a particularly increased risk. Especially if they were premature at birth, and like we said earlier, if there was any history of a premature rupture of membranes, or if there's any maternal group B strep infection in the past. Also, obviously, immunocompromised children, so unfortunately children can get cancer and need transplants and things like that too, so they can be on medications that can make them immunocompromised, or they might have like a primary immunodeficiency. Interestingly, although they might have a fever, an absence of fever and even hypothermia, when you check their temperature, can be seen in some patients when they get really unwell when they're little, especially if they're really young or they're immunocompromised. You want to check for any history of lethargy, any nausea and vomiting, any headache or abdominal pain, just because those are kind of key signs and symptoms of key focal points of infection. You want to take a really good history, and that can really help to determine the source of infection. And then you want to look for signs of shock on examination. But again, remember that children compensate really well. So just because they're not pusing particularly high doesn't mean you shouldn't be thinking sepsis in the back of your head if you're worried about infection. Also, I would say that in general, but with this in particular, parents know their kids really well. And if a parent thinks something is wrong, I would take them seriously, especially if they're not scoring on pews, and the parent is like adamant that something's wrong with their child. Go with it, investigate it, and often you'll find that actually there is something to it. And then make sure you're looking out for any signs of meningococcal disease, like a non-blanching rash or any signs of meningism. Okay. There's a really helpful risk scoring tool. A lot of the time these will be printed out in paediatric EDs, so that'll help you out. But it just kind of helps you identify, and this is for kids under 5 years of old with a fever, so it's kind of specific, but it will help identify whether they're low risk, intermediate risk, or high risk, and then what you'll do about it. And then management wise, the sepsis 6 is largely the same. However, there is a difference you'll see at the bottom here. You want to consider inotropic support early, so they might need admitting to ITU. Yeah, they might need inotropes to kind of keep that circulatory system going. Make sure you're correcting any hypoglycemia, identify any underlying infection source, and treat specifically. So I wanted to do a quick quiz. It does say that I've only got 5 minutes left for my meeting, so I'm slightly panicking, but we'll try and whiz through it. I was going to get you to pop the answers in the chat, but I think for the sake of time, I'll just read through the question and get you to think about it in your heads for a few minutes, and then I'll pop the answer on the screen. So question 1. Which of the following is not a key symptom of bruit or ULTI, according to the official definition? So remember, that's the brief, resolved, unexplained event. Which one of these is not a key symptom? Have a think about that for a minute. You can put it in the chat if you've got it straight to hand and you're ready to go. That's absolutely fine. So with this one, according to that definition I showed you at the start, drowsiness. So although you'd be worried about drowsiness, it's not part of the criteria per se. Question 2. An 18-month-old child is brought into the emergency department by paramedics. He's had a seizure at home, which has been witnessed by his parents, which spontaneously resolved after 2 minutes. Unfortunately, he started seizing again in the ambulance, and he's still seizing on entry to the ED. This second seizure has lasted 5 minutes so far. The paramedics have tried to cannulate him en route, but have not been successful. Which of the following is the best initial treatment option for this child? So the best initial treatment option for this child. Again, if you want to, you can pop it in the chat. Don't be shy. E, yeah, well done, Jasleen. No, that's a lie. Oh, it's because I'm not. I changed the order of the answers. It is E. I'll change the slides before I send them out to you. Yes, it's buccal midazolam, but I put it as B on that one and E on that one for some reason. Sorry, guys. Question 3. 6-year-old girl. She's come into the ED following an accident at school. She's jumped off a vault in gymnastics, missed the crash mat, landed on a hard surface. She's told the teacher that she landed on her ankle funny. She's in a lot of pain, and this is her x-ray. I hope you can see that okay. What would this fracture be classified as according to the Salter-Harris system? See a typer, so I'll give you a minute. Oh, we bailed. So this one is D, a type 4. Nice try though, Krishma, well done. So the reason that this is a type 4 is because you can see that you've got this horizontal one through the physeal plate, and then you've got this oblique one through the metaphysis and the epiphysis, and then you have this one right here as well. So that's a nasty one, that. Question 4. A 4-year-old boy is brought into A&E with increasing difficulty breathing over the past 2 hours. His parents say that he hasn't seemed himself the past 2 days, and he has had a cough since last night. The family recently moved here from Nigeria and are unable to remember which vaccinations he's had. And on examination, these are his OBS. So he's hypoxic. He has a heart rate of 80, respirate of 45, and he's got a high temperature. She. I've misgendered her. And she's drooling as well. So given the most likely diagnosis, what is the next best step in the management of this patient? Just for time's sake, so we can make sure to get onto feedback and questions, I'll skip through with this one, but hopefully you know that it is intubation. And that's because they've got worrying signs of acute epiglottitis, and we don't know the vaccination history, so that kind of increases your suspicion of that diagnosis as well. So you want to make sure that you've got a definitive airway in place in this condition. Okay, so sorry, that was a lot of information to get through in a short amount of time. I hope I've not just word vomited all over you and you're more confused than when you came. I would appreciate if you have a minute to fill out the feedback form. But if you have any questions, feel free to turn off your mic and ask me, or pop it in the chat and I'm more than happy to answer those. But yeah, if not, I hope that was helpful. Like I say, really, really hard to get through all of paediatric emergency medicine in an hour, but I hope that you took something away from today's session.